I'll get the speakers. I think Jeff, I don't think he needs any intro. Actually, he's one of the pioneers in the field of nodes. And Jeff, he's going to talk on endoluminal or transluminal endoscopic surgery. Jeff.
Good morning, GV. Thank you so much. If we can get our first slides up here. Well, I think the first telltale sign is looking at the room. Well, we got a big room for the meeting, but there's a lot of empty seats. I think 4 or 5 years ago, we would have found that this might have been out the door maybe with people. And I think a lot of, in terms of the interest of notes and the, it had its 15 minutes of fame or maybe not. I think you'll hear in the next 3 or 4 talks how that's going to go. So my initial task was to discuss endoluminal, transluminal. So as an endoscopic surgeon, notes kind of fell into our lap initially because we did a lot of endoscopy and we did a lot of surgery. And I think it's important to understand that all of the stuff that you're going to see in terms of endoluminal surgery couldn't have happened if it wasn't for the last 7, 8 years of notes research. So these are my disclosures. None of them should impact any of what I discussed with you today. So when we look at my objectives, basically, there are a lot of similarities and there are a lot of differences between what we would describe as endoluminal, or staying inside the lumen of, obviously, the GI tract, in the transluminal, and discuss some of the appropriate applications as well as some future indications and whether they're going to exist and how are they going to exist and what might we expect. And I think all the other speakers will give their, obviously, impression as well. So when you look at the history, obviously, of notes, it is a flexible endoscopic thing. And so when single site came around, or when people were putting rigid equipment through other orifices, we kind of were like, well, wait a second. We said this was natural orifice transluminal endoscopic surgery, and we kind of all based it on that endoscopic platform. So when we look at endoluminal therapies and transluminal therapies, they still have pretty similar flexible endoscopic platforms and scopes. And although there's been some changes and a couple things have come to FDA approval, really hasn't been a whole lot yet. A lot of accessories have been developed, or at least in the lab, and some of them have come to clinical use. And again, things like suturing and stapling devices as well have allowed some similarities between the endoluminal and transluminal stuff. One thing that I've always been trying to push when it comes to notes is that obviously the similarity that notes has to basic endoscopy, in that it can be done in a non-sterile environment, just like endoluminal therapies, and maybe under conscious sedation, just like doing a PEG or an EMR and things like that. Again, that's maybe one of the similarities, as I would tell you, is between endoluminal and transluminal. And they both may result in a viscous disruption. Nothing is to say that during an ESD, we're not going to make a hole in something. But after the 7, 8 years of all of the porcine work that we've done and all of the animal, human clinical experience that people have been reporting, making a hole isn't the terrible consequence that it was 10 or 20 years ago. And I think most of us now are much more comfortable with the idea, we make a hole, we'll close it. The peritoneal cavity has gained incredible respect in my mind in terms of the macrophage activation and clearance of bacteria. And I've gained all new respect for what the human body will tolerate when it comes to the way we do endoscopy and surgery. So what differences might we have between what we would describe as endoluminal and transluminal? Well, one, as I said, the transluminal has started using some rigid tools. People are using rigid staplers, rigid graspers through a transvaginal route. People have also tried, obviously through the umbilicus, okay? Is the embryologic orifice of the umbilicus considered notes? I'm not so sure. I think the other thing is that endoluminal therapies through history, okay, have been replacing surgery. I mean, how many people out there actually have done an open common bile duct exploration or done a colonoscopic, or a colotomy and a polypectomy? So when I look at the history of endoscopy, it's not so much to compare to surgery, but it's to replace it, to come up with a different way of doing things. And I think one of the things we've also learned over the last decade is that maybe we can change the way we manage GI disease, and it doesn't require a formal resection of major tissue. One of the things I think down the road that we're not discussing so much today is either image-guided therapies or genetic-guided therapies. Does someone really need a foot of colon taken out for a T1 lesion? And I think that's the kind of things that we'll learn 20 to 30 years down the road. Transluminal therapies, unfortunately, having been under the microscope, obviously for the last 6 or 7 years, are trying to be compared to surgery. And I think that's one of the downfalls of where Notes has gone, is that instead of coming up with the benefits that Notes might provide, we're trying to replace something, or to compare to something that has a pretty high bar. Okay, lap chole, let's be honest, as an outpatient half-hour procedure, is very hard to achieve a better procedure than that. The final thing is that endoluminal therapies are far less of a paradigm jump. And let's be honest, even though now we're much more comfortable making holes in organs, the idea of doing it without inadvertency is very hard for many people to accept. And I think that's one of the differences when it comes to discussing of endoluminal transluminal therapies. So when we look at endoluminal applications, basically it's obviously confined to GI diseases that we can reach by endoscopy. And with the single balloon and double balloon therapies now, I didn't list small bowel here because there isn't a whole lot of therapeutic things just yet, but I think we all would agree that the esophagus, stomach, and colon are easily accessed organs for most of the endoluminal therapies that we're looking at. And a lot of these are basically mucosal-based diseases, EMR, ESD. Now, EMR, for those of you that have never seen it, is basically just a glorified hemorrhoidectomy. Basically, we take a rubber band, we put it on some suspicious tissue, and then we snare it off. So it really is not a challenging procedure. ESD, however, is. All right? It's like taking the training wheels off of a bike and not knowing how to ride a bike. So ESD is a big step, but there are lots of new innovations coming out endoscopically with accessories as well as endoscope changes that will make ESD a more common day thing. So when we think of ESD in the Western world, it's probably much more in the colon, but when we think of it in Asian Pacific countries, obviously the esophagus and stomach with early cancers. And what about the concept of full thickness resection? As I said, just because it's endoluminal doesn't mean we can't make a full thickness hole, all right, and fix that. And the concept of full thickness resection, whether it be with flexible staplers or with suturing devices, again, I think are going to come to fruition, as well as intraluminal anastomoses, as well as mucosal or submucosal myotomies. What if we could treat achalasia through just a submucosal tunnel? You'll hear Dr. Inoue from Japan, I think, is going to the panel, I think either later today or tomorrow, talking about 30 cases of a submucosal myotomy for achalasia. No incisions, okay? And it's a new way of treating a previously laparoscopic disease. So what applications do we have for transluminal? Not a lot, okay? I think maybe some simple or diagnostic peritoneoscopies I think we would find are definitely approachable. PEG rescue, even though we've been the ones pushing it at Case Western, we've done a total of 10, of which 3 actually required it. 10 of them, the other 7, we did what's called a fistuloscopy. And I do think there is some advantage for organ retrieval. And you see a lot of it now, even if it's laparoscopic assisted, taking colonic specimens out through the anus, okay? And obviously the vagina has been used for transvaginal hysterectomies. And I think the concept of organ retrieval is something that we need to look at. Brian Duncan got a SAGES grant this year for looking at organ retrieval for kidneys for donor nephrectomy. And I think we need to do a little bit more research before we say that's actually an application. So basically, in conclusion, what I want to say is all of this stuff has been a parallel sequential process. None of the things that we're going to be doing in endoluminal therapies ever could have been done without all the work and the research and the efforts of the people over the last 6 or 7 years when it comes to transluminal procedure. And it really isn't one or the other. I mean, it's basically train cars running down tracks, but with obviously veins connecting them, all right? The single-site surgery would never have gotten any legs if it wasn't for all the single orifice access that we've been looking at. Endoluminal cases may become transluminal, and I think we need to accept that, but there are still limited transluminal applications right now. As we stand here in 2010, I think the endoluminal therapies are more easily accepted by all of us, by the patients, industry, the FDA and our IRBs, okay? And I think we all have to accept that. And I think what I would say basically is endoluminal surgery has taken advantage of this last 5 years of research and clinical experience. The endoscopic tool advancement, even though it's not as fast as we would have liked to have seen it when we started this 6, 7 years ago, but there are some tools that initially were developed for notes that are going to come to fruition and are going to come to be used in the intraluminal fashion. And I like to refer to this new avenue, okay, and this is not trademarked, okay, as what I would call noise, okay? So not notes anymore, it's noise, natural orifice intraluminal surgical endoscopy, and if one of you want to trademark it, go ahead. I mean, that's been, I think, the theme of the decade is trademarking different names. So when I look at endoluminal surgery, I look at it as a rocket ship powered basically by all of the work we've done the last 6 or 7 years, the fuel of the notes research. And when I look at transluminal surgery, I think it's kind of frozen in place right now, okay? Waiting to be thawed out, so to speak, like Austin Powers here. It's not dead, but I think we need to find an avenue for it down the road. Thank you very much.